Good morning, good afternoon, good evening, everyone, and welcome to the WFH Practical Education on Bleeding Disorders, Knowledge for All web series. We have initiated this during COVID over the past 2 years and are running 2 of these series this year, this month, and then in December. It's our pleasure to invite our speakers today. We have some very interesting topics that we'll be covering over these 2 hours. And I will start by talking about the topics. I'll mention our first 3 speakers, and then at the top of the next hour, I will introduce our next 3 speakers. So we're going to start with self-advocacy and adherence in teenagers. And Sue Cutter is going to do that. Sue is a licensed clinical social worker at the Penn Comprehensive Hemophilia and Thrombosis Program in Philadelphia, Pennsylvania, USA. And she's also the chair of our psychosocial committee at the WFH. Our next speaker will be Cesar Haddad from Beirut, and he'll be speaking on sports in adolescence. Cesar is a physiotherapist. He's been specialized in hemophilia care for the Lebanese Hemophilia Treatment Center for a number of years, and he is the chair of the WFH Musculoskeletal Committee. And then our third speaker in this hour will be speaking on transitions for adolescents, and it's Marlene Belleville. And Marlene is the hemophilia and research nurse at Amsterdam University and Medical Center in Amsterdam, the Netherlands. And she is also the chair of our WFH Nurses Committee. So we have 3 chairs of our committees that will be speaking with us during this first hour. With that, I would like to turn it over to Sue, who will initiate things. Sue?
Yes, I'm just 1 second.
Okay.
Hello, everyone. And in this session, you'll have the opportunity to learn a little bit more about adherence and self-advocacy related to hemophilia treatment. I included other populations in addition to teens as a comparison to highlight some of the challenges that teens go through with adherence that are greater challenges than sometimes other age groups go through. So what is an acceptable level of adherence in people with hemophilia? And most of what I'm focusing on is adherence with treatment, with factor product treatment, but it really applies to all levels of hemophilia adherence, whether it's with your appointments or participation in sports and activities. But studies have found that 75 to 80% are the minimum guidelines for excellent adherence medication for most chronic illnesses, especially in terms of dosing and timing. And for children with hemophilia, 80%, greater than 80% is the minimum definition for adherence in prophylaxis. An international survey of 147 treatment centers found that 90% of children with hemophilia on prophylaxis ages 0 to 12 have high or very high levels of adherence. And so that exceeds the 80% minimum acceptable rate. And you can see how far it drops in adolescents. Only 54% of adolescents with hemophilia on prophylaxis ages 13 to 18 have high or very high levels of adherence. So that's, you can think about intervention points that you can make between those age groups to try to help this level drop. But we all know adolescence is a time of increased risk-taking across the board, whether people have chronic illnesses or not. And so it's a challenge for patients, caregivers, adolescents, and the treatment team. A US study of children with hemophilia less than 12 years old, infused by their parents, had higher adherence than those who were self-infusing with prophylaxis. And so again, you can see that it drops even in below age 12, before adolescence, if people are doing their own infusions. Although it's impressive that they're able to do it at a young age, the adherence is not as great. But regardless of how treatment is administered, children under 12 have higher adherence prophylaxis than adults and then adolescents who are 12 to 18 years old. What are some primary motivators of adherence? Well, perceptions of their hemophilia, if adolescents are accepting of their hemophilia diagnosis, and if they believe in the necessity of treatment and the benefits of treatment, They're more likely to adhere. If they're experiencing symptoms or desire to prevent symptoms associated with bleeding, they're more likely to adhere. So perhaps if somebody is on a sports team and they want to make sure that they can play on game day, maybe they're going to be a little more adherent during their season of sport, so they can be more adherent and be able to play. And if they anticipate a positive outcome for treatment. And incorporating it into their lifestyle, incorporating adherence is increased if they're really knowledgeable about their hemophilia and their prophylaxis, and they have keen assessment skills. And that often self-mastery of infusion skills and also proactive planning, some of that takes a while to develop. And if you think about it, adolescents don't have their full executive brain function, executive function in their brain. And so that often doesn't happen until you're in your middle late 20s. So that's also another piece to be aware of. Potential adherence challenges. It's important for us as staff to know the primary motivators, but that's really only the start. It's essential for our team to recognize and to treat each patient as an individual, to really assess what their adherence challenges are, and to have them to tease them out and really dig deep into what's going on, and include their families and caregivers in this process. And especially to identify the needs and preferences for adolescents. Other challenges, it's burdensome to consider health issues every day. And teens, and more so in teens who want to really appear normal and be like everybody else. And so you think 365 days a year, they're having to think about their hemophilia, their treatment, and all that goes along with it. Self-care of hemophilia is complex and requires highly technical skills, as I said, and early mastery at an early age. So we're asking adolescents to take on a lot of tasks related to their care and treatment when they're pretty young, and when most other children aren't having to deal with such things. Communication, cultural, and or resource barriers can pose challenges. Injections, as we know, can often be painful for some people, and also accessing veins can be difficult. If they're forgetful, that also makes it more challenging. And maladaptive behaviors or low coping skills within a family system. If the family system has poor coping in general, they're less likely to adhere. And if the adolescent themselves is in denial or has depression, they're less likely to adhere. Lack of self-efficacy can inhibit adherence. If an adolescent has a parent or caregiver who is overfunctioning, that often can lead to the adolescent themselves underfunctioning, not just in the world of hemophilia or chronic illness, but in the world in general. And so that also has potential to decrease adherence. And for those of us as HTC providers, that's another important thing for us to be aware of and see where we can intervene on that. I mentioned cultural influences can impact adherence, and it's important for us as staff to work together with patients and with their parents and caregivers to identify key family and community influencers, and if they're receptive to it, to bring them into the assessment picture if there are challenges, and all the while being mindful of race, religion, gender, and age, and other things that may impact adherence. It's important for us to assess both patient and family and caregiver health literacy, and identify insurance and financial barriers. If you live in the United States and you don't have insurance, you can get access to emergent factor and donated factor or trials of factor, but it's very challenging to be able to be on prophylaxis. And if you live in a country where factor products are very rare or hard to come by, you can't adhere to treatment recommendations if you don't have access to it. Some strategies we can use to enhance adherence. It's been shown that when hemophilia center staff and patients and adolescents and their parents and caregivers have strong relationships, if they have trusting relationships, then even adolescents are more likely to open up and talk with you. And open communication helps to enhance adherence with medical recommendations. And it's important for us to assess and not assume, and especially with this age group, because somebody can grow up a lot in a year. And or in 6 months if we see them every 6 months. And so remember, we are all capable of change, regardless of our age, and even if there's a past history of non-adherence. And I've seen this with older adults too. And so it's just important for us to keep in mind. It's also, again, important to utilize an individual approach and based on patients' and families' knowledge, behavior, beliefs, and desires. And it's our responsibility as providers to work together with adolescents and their family or their caregivers and parents to identify and solve issues related to non-adherence. And really, if we don't tease out what they are, and we just throw at them, this is why you should hear, this is why it's important. But if we don't tease out what's getting in the way of adherence, then it doesn't really enhance our ability to, or the patient's ability to want to adhere if we haven't figured out what's really meaningful to them around adherence. Oops. Can we go back? I can't see the, sorry. I can't see the slide arrows. Okay, so here we go. I can see them now. Sorry about that. And strategies to enhance adherence. Assess for depression as it can negatively impact adherence. Differentiate between types of forgetfulness. If it's intentional, like somebody just opted not to do their infusion, versus non-intentional. The adolescent kid got up late and he didn't even think about it, just grabbed the stuff and ran to school. Or, it was the end of the day and they went to bed and they were tired and they didn't even think about it. And it's important to differentiate between them deliberately opting not to do it and them just accidentally forgetting, because the interventions that we have are different, whether it's intentional or non-intentional, the interventions that we have as staff to intervene. Provide positive reinforcement for all progress, no matter how small, towards adherence, and facilitate and or encourage peer mentoring opportunities to foster adherence. We've seen, those of us that work in treatment centers, as well as patients and families, have seen the power of peer mentoring in hemophilia. Many of our patients who are adults first learned to infuse when they went to camp, because if they had been reticent to learn infusion before, when they went to camp and they saw their same aged or older peers being proficient with it, it often motivated them to want to learn, and they saw the independence it gave them. We can, as staff, we can use highly participatory counseling techniques to encourage sustained adherence. Motivational interviewing is highly personalized brief counseling that is aimed at behavior change, in preparing patients for behavior change, and has been found to be effective in improving health promotion activities, including in patients with bleeding disorders, and also to use other behavioral change counseling techniques such as cognitive behavioral therapy or Prochaska's stages of change. Gentle counseling or prodding can move them along in that direction too. Providing ongoing psychosocial counseling through your center. It can tease out what else is maybe going on in the adolescent's life that is inhibiting their ability to adhere, and encourage habit. Adherence has been shown to be more influenced by habit than intention, according to a study by Dishman. And present it as an opportunity for patients to serve as a role model, because if it's an older adolescent and they have a younger sibling that has hemophilia also, or a younger cousin, and they see the younger family member following their footsteps and not adhering as well, they may want better for their younger sibling, and so that might prod them to adhere. Next, we're moving on to self-advocacy and patient empowerment. And it's very important for patients to learn at an early age to be an active participant in their care. And part of that is helping them to build confidence and in encouraging them to openly express themselves and their needs and what they want. It's important for them to be proactive as a role in the consumer in this capacity, and for them to allow their voice to be heard, or as Sheryl Sandberg said in her book, Leaning In, have a seat at the table. And when we are self-empowered, when we are an active participant in our care, it's easier for us to assume responsibility for our own welfare. And when we do that, we're more likely to adhere. So the better the better a person is at self-advocating for themselves and participating in their care, the more likely they will be to adhere. And if, and this is for parents and caregivers to consider too, if it's important for your child, your adolescent, as well as both parents and caregivers to really find medical providers who they trust and they're comfortable with. If we are self-empowered and we are able to have open communication with our providers to evaluate treatment options and discuss them with the healthcare team, and even if we don't agree with everything that's offered, or we're not ready to do it, or we want to ramp up to adherence or ramp up to making changes, be willing to offer to your healthcare provider alternative solutions. Maybe there are other options that you can do partially while you ramp up. And communicate your needs. Open communication is one way to diffuse anxiety when you're speaking with your healthcare provider. So it really, we don't know if an adolescent isn't letting us know what their needs are, or the patients and their parents and caregivers aren't letting us know. It's hard to guess, and it's hard to know what they're feeling anxious about or concerned about. And so once they do that, it really can get something off their chest and let them move forward. And the best way to get what you want is to ask for it. And it's important to be mindful, though, that it's not always what you're saying, but how you say it. And so if the adolescent or their parent or caregiver comes to the table in a way where they have very strong emotions or body language, they're less likely to be heard. And so it's important to self-regulate your verbal and nonverbal behavior so people can have the opportunity to hear you better. And to listen actively, and this is for both sides of the table. It's for the treatment center staff as well as the adolescent and the adolescent's family. When the adolescent's talking, it's really important for us to listen actively, to pay attention to what they're saying and not be thinking about what we want to say next or what we want to propose next, but just really hear what they have to say and vice versa. And be able to consider multiple options and anticipate consequences for decisions. And assume responsibility for your actions and decisions, but also adolescents should give themselves permission to change their mind. If they agree to one thing and it partially works but doesn't completely work, they can go back and rediscuss it. And same for the team, and same for the parents and caregivers. And in terms of communicating your needs, it's important to maintain a firm and reasonable tone, be persistent, keep asking until you're satisfied with the answer. Persistence is one of the key factors in resiliency. And so if people learn to do this at an early age, it can bring them a lifetime of resilience. Remind yourself no one is always right. Be open to compromise. And keep in mind that the quality of the relationships between the HTC staff and patients is a key component to both adherence and patient empowerment. And it's not unusual for us as HTC staff to spend our majority of our careers in hemophilia care. And that gives many opportunities for staff, patients, and families to build strong working relationships and to repair communication difficulties that may arise along the way. Thank you.
Thanks, Sue. You've reminded us of how difficult it is for each of us to go through our adolescent years. With that, we're going to hold questions until the end of this hour. Cesar, you're up.
Thank you. Hello, everybody. And I'm very excited to be here with you today to discuss more details about the sports in the adolescent phase. For the agenda, of course, before talking about sports, we need to discover and know more details about adolescence, about the muscular development, about the benefit of physical activity, and then at the end, you have to choose if you still want to go to do sports or not. So before we start, I would like you to look at this picture and think about all these people. And there is a lot of other people that I see and I follow through social media. And I want you to think what is common between all of them. I know that they are all high-end athletes. And at the same time, they have worked very hard. they have all the discipline and all the challenges, and they have been training for so long in order to be able to reach a high-end athleticism level. And of course, also the common thing between all of these athletes is that they all have bleeding disorder. So a person with bleeding disorder is able to participate in sports, but we need to listen very well to this presentation before trying to start any kind of sports. In our practices, and especially as a physiotherapist myself, we hear a lot of parents asking us for advice if our kid or our young teen wants to participate in any kind of sports. What do you recommend? And I sit for between myself and start thinking, what should I say to this family? If I say no, they cannot do any sports, and I will be ruining their psychological level because I am stopping them from doing something that they can explore. And at the same time, if I say yes, they can do sports, I would be ruining their joints if they are not choosing the right sports. So it is for me a very tough question, and I sit before giving you my answer and what I say to this patient, we are going to discover more in these slides. So adolescence is a very critical phase in our life. It's a transitional stage with many physical and psychological development and phases. So generally, a rapid physical growth and psychological changes occur for the bones, for the muscles, for the circulatory system. So everything is changing. And not only on the physical level, but also on the cognitive abilities. Whenever the children is no more under the supervision or under the control of his parents, they are revolting. They are starting to discover themselves what they want to be in the future, what they want to do, what they are taking their own decisions. So consider at this phase the emotional pressure that this child or this teen is going through. So the parents doesn't want to leave them from supervision, and the child or the young teen wants to take the decision himself. It's a very critical stage. So, and what about the physical activity? Coming from a country with limited resources, I see a lot of parental control and overprotection. And this is very understood because there is not a lot of clotting factor available because as you all know, hemophilia or other bleeding disorder have tendency to increase the risk of creating any joint and synovitis and leads to functional disability. And this also is very doubled in countries with limited resources. So this is the case still going, not only it is in the literature, but we still face this every day. So, but if we don't do any physical activity, we will see a lot of people, it's not only for hemophilia, for anyone who doesn't do any physical activity or any types of sports, they will start losing their muscle, they will start having some physical dysfunction, functional disabilities. Of course, obesity is one of the most important that we see in people who are not very active, and osteoporosis. And I want to highlight on the importance of osteoporosis because bones and the strength of the bones is getting mature and stronger at this phase. Whenever we ask from our body more physical activity, we would be strengthening our bones. Which will help us prevent the osteoporosis on the long term. And of course, whenever you don't do any physical activity, you are not interacting with any people, you have a lower self-esteem compared to others. So for people with hemophilia in specific, as you know, because of the control or overprotection from their parents during the children stage of life, they will be less fit usually, they have lower aerobic exercise tolerance, and they have a tendency to be more overweight than others. And this has been shown through many studies, and I wanted to highlight on this randomized control study who showed that at the age of adulthood for people, normal people, and they compared it to the strengths of the muscle between normal people and people with hemophilia. And this study have shown that, for example, for the quadriceps muscles in adult, the person with hemophilia is 30% weaker than the normal population. And this is understood because of what we were saying, the limited abilities, the limited movement, the repetitive joint bleeding, and I highlighted in yellow the insufficient rehabilitation post-bleeding. Usually, we see a lot of people saying, okay, we took the clotting factor and we go back to our function and physical abilities the way we used to do. And there, where happen a repeated bleed again and again. So there is no rehabilitation and no proper follow-up with people. So it's very important to rehabilitate and to ask from expert opinion after the bleeding in the joint that happens. And I want you to see also the impact of sports on the cartilage. It's not only we discussed about bones, but also about the cartilage. The cartilage is a smooth, lubricated surface. It is avascular. It doesn't have any blood vessels inside the cartilage. And whenever there is limited activity, the inactivity leads to degradation and degeneration of this cartilage. So whenever we ask and we put mechanical stress by moving, by being physically active, by doing sports, we would be helping our cartilage to be stronger and stronger. But the amount of the dynamic compression during moderate exercise can prevent osteoarthritis. So whenever we do any type of activities, it's very good to strengthen the cartilage, but overloading may damage the cartilage. So this is where we have to interrupt and say, okay, this activity is intensive, or this activity is good for us to be able to participate or not do. I will discuss about the importance of exercise in itself, because it is very well known and very well studied that exercise is able to reduce pain, to regain the range of motion if there is any limitation, reinforce the muscles, and improve walking tolerance. And it has been shown that it can decrease the bleeding tendency because of the strong muscles, and muscles surround the joints. They build a certain shield around the joint. So having strong muscles, it's very important to decrease the bleeding inside the joints. I want you to think about this, because whenever we are advising any kind of sports for the patient, for the adolescent is full of energy. The adolescent is full of enthusiasm. They want to participate in just anything, to be like their peers, to not be discriminated like others. But what I do, what I say to my patient who come to our practice, you have to know your limitation. You have to think that your body is like a super fast car, like a Ferrari or very fast car. And it is very strong, it is very fast, it is very beautiful and shiny. But you are the driver of this car. So you need to use your brain. You are the leader. You should lead. You are responsible for this car, for keeping this car away from accidents. So if you don't know how to drive, you may lead yourself into accidents. So it's very important, the body awareness, to know our limitation, to know where to stop and how to do the exercise or the sports very properly. We should know the techniques properly before doing any kind of exercises. I hear a lot of time from a patient, okay, we cannot participate in sports because we don't have time, we have school, we have, sport is very expensive, and also in addition for patient with hemophilia, there is pain, there is fear of bleeding. We have a role to introduce the importance of sports for these patients with hemophilia and to show them that they must try to find some time to do some sport and stop putting any causes and reasons for not going to sports. So it is very important that sports become as part of our life, because it's, as we see, very helpful and reduce the amount of bleeding and have stronger bones on whenever we are older. Sports and implementation is based on 4 elements. At first, we have to, we need to have the mental acceptance. We need to convince. It's not something like whenever they were young or children, the parents would tell their child, you can go, you should go, and you do this by obliging them. But whenever it's adolescent phase, it's the mental acceptance. They have to be convinced. They have to agree on what they are doing. Then when they agree, they will be willing to accept this change, and it becomes a part of their lifestyle modification, which also is affected by the physical abilities if they don't have any limitation in their joints or so. So how can we initiate or motivate the adolescent to do some sports? There is these 2 types. Either there is the carrot method, we reward the patient, okay, you are doing good, you can participate in some kind of sports or something. Or either we can show them that if you don't do sports, look at what will happen, what might happen to your joint whenever you are not physically active. So it's very important to work on introducing the idea of being physically active and the importance of sports, but of course with certain limitation. Some specific consideration before sports, of course, as I said, there is some specific consideration to take. The first is the availability of sufficient clotting factor. Not available clotting factor does not mean you cannot do any sports, but of course it has to be a little bit limited based on your joint status and joint health. If you have any muscular or joint limitations, synovial problems, targeted joints, you need to choose the proper sport for this, the type of sports, and to be individualized. For example, as you all know, and of course you have heard that for people with hemophilia, swimming is the best sport to do. But I hear a lot of time from people, they don't like swimming. So if they don't like it, it's not an obligatory thing to do. They can choose a different type of sports and they can try to do it with them. And whenever they are training, there is not only, I see, especially in teenagers, they try to work on their strengths, to have a volume, to have a beautiful body, but they forget to work on coordination, endurance, and flexibility as well. So a muscle is considered to be not only strengths, but it has different components that we need to look at. We need to show the adolescent what to do and to have clear verbal instruction on what they have to do. A lot of misconception that people with hemophilia have. For example, teenagers shouldn't start strength training until they reach maturity, and it's not right. They can do sports and they can participate, so it's not a problem for this. Sports is expensive. I know a lot of sports are expensive, but you can do a lot of other sports that do not cost a lot. All sports require similar level of athleticism and sport-specific skills. It's wrong, because every types of sports has its own specificity. So whenever you are swimming, you need to build stronger upper body muscle, for example, or whenever you are hiking, you need different types of muscle. So it's not the same for every type of sports. So teens do not need to stretch. No, it's wrong also. They need to stretch. And more training equal more muscle. It's not right. I see a lot of people staying at the gym for hours without having a difference in their strength. So it's not right. Choosing the right sports, you will see a lot of booklets and guidelines about this is bad, this is good, this is dangerous for your body. I know sometimes we commit, sometimes we don't. I see a lot of people participating in football or basketball. The most important is not only not participating in contact sport, but also if you wanted to do it, you must be able to know what are your limitations and what are the protective tools that you need to do to put and to use. Specific consideration for sports, of course, wearing, as I said, proper equipment, strengthening the muscle, because if you don't have strong muscle, all the pressure will go onto your joint, and this is very bad to your joint for the long term. So you need strong muscle to support your body and not put pressure on your joints. Increased flexibility, of course, taking a lot of breaks between training, using proper techniques. You have to know what are the techniques. You have to obey to strict rules. And I put this in capital letter. No training through pain is allowed. Whenever you have any kind of pain, you should immediately stop your training and ask for experts' opinion. And of course, a proper diet and drinking is very important. The most important is to use your brain. As I said, you have a Ferrari, a very beautiful car, but if you don't know how to drive it, you will lead yourself to many accidents in life. So the take-home messages: sport should not provoke any pain. Emphasize on the process over the result. I see a lot of young teens who want to build stronger muscle and very nice bodies, but they forget that this body and the good muscle is very good muscular support is for the long term, not only for its beauty part, but for its function. Building team confidence and involving them. Simplicity is the rule. Offer something new to stimulate the teens and understand that what is fun for you isn't always fun for the teens. So you need to discuss with the teen, as Sue said before, about the importance to discuss as advice. So my answer for this, the questions that we asked at the beginning: you can participate in sport, of course, yes, but there is always about you need to have a clear brain and use your brain to know your limitation and know where to stop and how to use proper technique for sports. And by this, I want to thank you.
Well, thanks, Cesar. That was one of the most practical talks I've heard. And although it was focused on adolescents, it applies to the rest of us as well. So appreciate that. Are consistent with the theme that we are doing in this first hour with adolescents. We're going to continue with Marlene, who is going to provide the nursing perspective. Marlene.
Hello all, I hope you can hear me well. My presentation has got the title Goodbye Pediatrician, and that is because we have in recent years the transition from pediatric to adult care has had so many attention, and healthcare providers have become more and more aware of the needs for adolescents and young adults, especially with chronic diseases. And as we heard already from Cesar and from Sue, especially the adolescents are a difficult group of children patients. I'm going to the next slide. Yeah. So as we all know, a bleeding disorder is a lifetime condition. It is often diagnosed in the childhood. And since there are so many advantages in diagnosis and treatment lately, that the life has significantly improved in the recent years. Care for children is, but also for adults, is often provided by a multidisciplinary team, in children's cases by a pediatric hematologist, a nurse, of course, physiotherapist, psychologists, and all kinds of other specialists. And but not only if you have hemophilia, but for all people, you and me, but also all the hemophilia patients and patients with other bleeding disorders, throughout our life, we have a lot of transitions to make. It already starts at birth, where you are so dependent of your parents. You can't do anything at all when you're a baby. And throughout your childhood, you get more and more independent from your parents. But one of the most difficult transitions in life is the transition from childhood to adulthood. And because that is what already Sue and Cesar mentioned, there are a lot of complex biological, social, and emotional changes in this period of time. Adolescents, they develop their own personal identities. They become independent of their parents. They begin starting to do education, start jobs, and they build their own important relationship outside the families where they are born. And we don't know the exact period for transition from childhood to adulthood. It varies from person to person. Very often, adolescent is defined as a period from 10 to 19 years, but it can also be based on the young people's own biopsychosocial readiness for adulthood. And like many other lifelong transition, this is an inevitable one, but very important transition to adulthood, because it is important that the adolescent with a bleeding disorder takes care of their own disease. Oh, that is going too quick. One page up. And although pediatricians and all the team members within a hemophilia treatment team work together, there are differences between adult care and pediatric care, where in pediatric care, most of the care involves in dealing with the parents or the siblings and even grandparents. And from an early age on, it is parental support. The care is family-centered, and the parents are responsible for their child's care and their treatment. But in adult care, we assume that the patient's it's the patient's own responsibility to care of his health care. And depending on the severity of the bleeding disorder, a patient is seen frequently or less frequently in, for instance, follow-ups. So patients have to be prepared to be responsible for their own care, and that they should actively approach their hemophilia treatment team in case of any questions or help in their care. So after a lifetime of pediatric care, adolescents with a bleeding disorder often enter a completely new team with different doctors, maybe different nurses, maybe other physiotherapies, and perhaps in a completely different hospital or in a different city. What we all need to be aware of is that transition is not a moment. It is not one particular moment. It is not, there is not one way to do the transition. And if we have an unprepared transition from adolescence to adulthood, it may contribute to a decreased adherence, like Sue already mentioned. And it might cause any loss to patients to follow up in their treatment or in their relationship with the new hemophilia treatment team. So we must ensure that patients, their parents, that they are well supported in this transition to adulthood, but also that caregivers are well trained and that the transition program meet the needs of all participants so that the adolescent can seamlessly transition into their next stage of life. So who are all those stakeholders? There are many of them. There are, of course, the parents and the adolescents, but the pediatrician, the nurse, the physiotherapist, and also the adult practitioner. So everyone in this process has got his own task, but how do you ensure that everyone also works together and is on the same page in preparing an adolescent in their way to adulthood? The most important participant is this adolescent. And like Cesar already mentioned, they have to use their brain to do whatever sports or to adhere to their treatment, but that is extremely difficult for an adolescent because their brain is still developing and they often make the wrong choices, not on purpose, but because they can't oversee the consequences of many choices they make. So if you look at transition, there are worldwide many transition tools, and it is important that all the stakeholders in the transition care achieve a smooth transition. And one way to achieve this is to formulate guidelines, and preferably that the vision of the patient's treatment and the working methods is set down in a guideline in writing. That, for example, there is a policy plan for transition in a protocol. And in this way, a structurable, testable way of working can improve the transition. Often it is really good to have a coordinator, for instance, a nurse, who can coordinate the whole process of the transition. And within the hemophilia team, it is often the nurse or the nurse practitioner who can do this, because they are they play a key role between all the stakeholders in this transition process. But during this transition, we have to be aware that, is this special patient of yours ready? Is he as mature as you think he is? Like Cesar already said, is his cognitive ability good enough to take care of himself? Is he able to self-infuse, or is he scared to do it? Is he still dependent on his parent, or is he having anxiety to self-infuse? As I already said, their brain is so different than from adults. Are they able to stay healthy? Are they able to make the right choices in their treatment, for instance, concerning their prophylaxis or a bleed? Are they able to manage their own disease? And are they able to avoid any complications concerning their disease? In our own hemophilia treatment patients, we start already by keeping good records of what is discussed and how far parents and children from an early age on are in their process of knowledge and also the practice of their treatment. We begin at the time of the diagnosis and trying to ensure that a seamless transition throughout the whole childhood until the transition to adulthood is being taken care of. And as you can see in this slide, the adolescent is getting more and more responsibilities by the time he's getting older. I personally think the most important point of transition is that you are always able to discuss it with your adolescents. Of course, like Sue already mentioned also, they must have a lot of questions, but are they able to talk about it? Are they able to discuss it with either their parents or a caregiver? They must have questions about the future, about insurance, about can I do every work when I'm an adult? How about relationship? Can I use alcohol? What about sexual relationships? What will my future be like? Of course, they will discuss this with their peers, but their peers might not have a bleeding disorders. So how can we discuss this with our adolescents? And then a tool I often use is this one. I call it a tool for conversation. All kinds of topics are mentioned in this tool. And when I see an adolescent in my own care, then I always encourage them to talk about one of these tools. They can choose one topic on this tool where they are proud of and what they want to talk about. So in this way, I try to encourage them to talk about themselves. And then often I experience that there are coming the questions which we want to hear from them, but which they might find difficult to discuss. And if you try to encourage them in this positive way, you have a whole different kind of conversation with this very difficult teenagers, adolescents, children. And if they have chosen two topics where they want to talk about, where they are proud of what they have achieved in their life, then I say always, can I choose one topic to discuss as well? And I often choose this one, the lifestyle. And that is opening up a way of discussing things that is important in their life with their bleeding disorder. I often try to give examples, like if you go with your peers and you drink alcohol, why is it more important for you to keep control about your body? And to try to discuss this, you can slowly prepare adolescents for the most important step in their life, which is becoming an adult. So if I summarize, it is very important that the complete team of all the healthcare givers, but also the adolescent himself and the parents, they must all have the same goal. It is important as a team to regularly evaluate the issues that are working well during this transition process and what is not going so very well. And then you can make adjustments in this transition process so that no patients will be lost from the care after they have transitioned to adult care. So I wanted to keep it short because we were running a little bit out of time. And Glenn, I think we are now back to in time, I'd like to show you my reference. Oh no, that my last one was that we need a lot of compassion from involved parents, from continuity in care, and to coordinate it very well. And it is a difficult process. We have to do it with the whole team, but also with the adolescent and the parents. So these are my references, and I think we are going to the questions and answers now. I'd like to thank you for listening.
All right, thank you very much, Marlene. That gives us a very complete view of adolescence. So we've got time for a few questions. I do want to remind the audience that this whole webinar will be up and online at our education site within 1 to 2 weeks. So check back at the end of the month, and you should be able to find all of the presentations there. We've gotten a couple of questions. Let me start off by asking Sue to comment a little bit on a question from Uzima. What strategies can be used for improving adherence rates of people who've been reported to decrease those rates in late childhood and adolescence?
That's a great question. Thank you. Really, it depends. It's often situational. And it's not uncommon for those rates to fall in other areas of adolescence life with adherence as well. And so it's really important to sit down with the adolescent and try to tease out what's going on and ask open-ended questions, because it may be related to their forgetting, and is it intentional or unintentional? It may be relating to maybe they're having increased mental health issues. Maybe something happened with their peers and they're feeling more isolated, or they're feeling more anxious or depressed, or there's some substance use, any number of things. There's changes in family functioning, and they may or may not be fully open with you about it, but even if you can give a little opening in a window to find out what's going on, or it may just be that they're not that proactive with their planning, or they're having more trouble with their infusions, or they're finding them more painful, or they're staying up really late, they get up late, they don't have time to do it before they go to school, and then they're out later doing whatever, and they don't remember when they get home. And so it really depends what the cause is for it. Is it related to mental health issues? Is it related to family dysfunction in general? Is it related to wanting to be like their peers and not appear different? Is it related to busy schedules? So once you find out what it is, it helps you with your interventions. And it's also important to check in with the parent and the caregiver to find out, to see if they're even aware, and what's going on within the family, and if the story you're getting is pretty similar on both ends. And kids aren't necessarily open with their parents or caregiver, or even with us as providers. But if you have a strong relationship with them and you keep the information they tell you confidential when it's appropriate, then I think you're more likely to find out what's going on.
Okay. All right. Thank you, Sue. One more question here, and this is for Cesar from Sabrina, a 15-year-old who's got 28% factor, who has had bleeds, perhaps because he's playing baseball, and the treatment center won't start him on prophylaxis. You have any short thoughts on how to approach that? And Sue and Marlene, you can feel free to chime in too, but let's keep the answers short.
Yes, at first I would like to, of course, the intervention of hematologist with me, because it's a very difficult, or it has a little bit of complication. Of course, they can do some kind of sports. That's what we recommend, but they need to have proper equipment for baseball to protect them. And if it was possible, I don't know the opinion of hematologists, to whenever the days that they have, it's during contact sport, it's very important to be on a good level of prophylactic treatment or factor level treatment. So if it was possible, in addition to the safety elements to be wearing and everything, to have a proper factor level, it would be better and beneficial.
Okay, Sue or Marlene, anything to add to that kind of a situation?
Yeah, what I'd like to add is that maybe there is a possibility to put them on temporarily prophylaxis to prevent him, or to let him contact with peers who are already older, because it is very difficult to let them stop a sport if they want to do the sport. Maybe if they have got some contact with peers who have been doing the same sport but stopped due to bleeds, then they might be better able to understand and accept it if they hear it from a peer than from a healthcare professional.
Okay, all right, thank you, Marlene. Let's go on to our second hour, and we'll have 3 talks. They'll be more clinically oriented, and then we'll have time for some questions at that point too. So it's my pleasure to welcome our first speaker, Miguel Escobar. Miguel is professor at the McGovern Medical School at the University of Texas in Houston. He is also one of my colleagues on the WFH Board of Directors as a medical member, and has been the chair of the International Hemophilia Training Center Committee for a number of years. And that committee has just celebrated their 50th anniversary of training individuals in treatment centers around the world. So it's our pleasure to welcome him to talk on hemophilia B. We think of hemophilia A and hemophilia B sometimes interchangeably, but there are some distinct differences between the two, and he'll go into that. It's also my pleasure to welcome Sukesh Nair to speak on assays and reagents, a never-ending story as newer products come out. Sukesh is professor of laboratory hematology at the Christian Medical College in Vellore, India. And he is the past chair of our Laboratory Science Committee and our WFH EAQUAS committee, which is our quality control group. And so Sukesh will give us some updates on the latest in assay developments. And then our third speaker is Annette von Drygalski. And Annette is professor of clinical medicine and director of the Hemophilia and Thrombosis Treatment Center at the University of California, San Diego. Right here where I am located. And Annette has been that treatment center head for 10, 12 years or so now, and has done a tremendous amount of work on musculoskeletal ultrasound to detect bleeding episodes and to do joint evaluations in bleeds in hemophilia. She's also been actively involved in getting Mozambique to a membership status with the WFH, bringing a patient group together, a hemophilia treatment center together there in collaboration with her colleagues at UCSD. And so she's been very instrumental in moving care forward in that country. So she'll finish us up, and then we will get into questions and answers. Miguel, it's all yours.
Good morning. Thank you, Glenn, for the introduction. And as you said, I'm just going to give you kind of an overview of hemophilia B, but trying to compare it to hemophilia A. And, hopefully you'll get some important information here. These are my disclosures and from the university where I work as well. So I'd like to start with some statistics so you can get an idea of the number of patients that we're talking about, specifically hemophilia B. We certainly know that hemophilia A is much more common, so maybe there's about 5 times more hemophilia A than hemophilia B patients. But based on the statistics and the calculations, it's maybe 5 or every 100,000 male for hemophilia B, and maybe 1.5 severe hemophilia Bs for every 100,000 males. Now, if about 130 million babies are born every year, we estimate that there's about 20,000 people then with hemophilia every year that are born. And of these, about 7,000 are going to have severe hemophilia every year. So you start adding up the numbers and, certainly it starts getting, much larger and larger. Now, if we assume that there is about 3.9 billion males right now in the world, we expect that the number of patients with hemophilia worldwide is over 800,000. And of the ones that have severe hemophilia A and B, it's going to be over 275,000 patients. Now, certainly this is not what we've seen in the reports, because there's probably an underreporting of patients with hemophilia, but this is based on statistics. These are the number of patients with both hemophilia A and B that we expect to see or have in the world right now. Now, this report is coming from the World Federation of Hemophilia Annual Global Survey. These are countries that participate and give their information. And what we see here, that there's only about 209,000 number of people with hemophilia that has been identified. Of these, about 165,000 with hemophilia A, but only about 33,000 patients with hemophilia B. Now, there's still a number of individuals that have not been identified between A or B, and that's about 11,000 patients, or maybe a third of these are going to be hemophilia B patients. Right now, to getting into the factor IX, you guys are familiar with the gene of factor IX. This was cloned about 40 years ago in the 1980s, and there are some differences certainly compared to the factor A gene. The factor IX gene spans of about 34 kilobases. It's located in the chromosome X, and it consists of 8 exons and 7 introns. We know that the coding sequence is going to translate into the factor IX precursor. That is going to have then it's going to have for example, the signal peptide, the propeptide, the GLA domain, 2 of the EGF domains, there's got a linker sequence as well. But, the factor IX is the precursor is going to undergo multiple post-translational modifications, especially the gamma carboxylation is very important. And then it's going to be processed and becomes a mature factor IX molecule that's going to be secreted into the extravascular space. Now, the inactive factor IX zymogen then is going to be activated, by cleavage of the activation peptide factor IXA, which at the end is going to contain that light chain and the heavy chain that is linked by a disulfide bond. Now, if we look now at the genetics, or the genetic part of both hemophilia A and B, we see there are also some differences. This data comes from about over 3,700 patients that was last looked at in January of this year. And we see there's just over 1,000 different mutations in hemophilia B, which is a quite large database. Now, about 88% of the patients of hemophilia B are going to carry point mutations, very different from hemophilia A, and about 12% only of the patients with hemophilia B are going to have deletions, insertions, or duplications. Again, that is a quite difference when you compare to hemophilia A. Now, this data again comes from the survey done by the World Federation of Hemophilia, and is looking at factor usage in 2019 and in 2020. And we see here to the left the number of hemophilia A and B patients that have been identified around the world, and the total consumption as well of factor between the two diseases. We see that from 2019 to 20, there has been a slight increase in the per capita use of factor IX, which I think is very important. And this could be from, due to many reasons. One of them is, maybe we're doing more prophylaxis in our patients with hemophilia B, but also has to probably do to the humanitarian aid program also that the World Federation of Hemophilia has in certain countries. But you see there is different. Now, when you compare definitely to hemophilia A, it is a huge difference, in terms of the amount of product, knowing that there are less patients with hemophilia B as well. Now, here we have some examples of the different countries, the mean capital use of factor IX in 2020, both in the Americas and Europe. And you see there is a huge variability. We have a standard half-life factor IX, which is the solid bars. And we have then the use of the extended half-life. We see again that some countries, there's a very large per capita use, like it's Italy, Lithuania, and then in North America as well. But we also see that many countries, the per capita, the mean per capita use is quite small in many of these countries. Here we have just looking at an example of some of the countries, the distribution between plasma-derived, extended half-life, and the standard half-life factor 9. Again, a lot of some of the countries, the use of it is maybe more based on the humanitarian aid programs that the World Federation of Hemophilia has. Now, this is one of the most important slides that I'm going to be showing. And this is the percentage of patients on prophylaxis in 2020. Again, these are reports from the different countries. And we can see, for example, in those patients that are under the age of 18 on prophylaxis, it is, quite positive. I think that most of the countries are doing an excellent job on doing prophylaxis on the patients that are under the age of 18. Here, I cannot differentiate between hemophilia A and B, but we assume that there's a grand majority of patients that have hemophilia A. Now, when we looked at patients that are under the age of 18, you see that there is a dramatic decrease in the amount of prophylaxis. And I think this is quite worrisome, right? But it could be many reasons why this is happening. Again, some of them could be because there are certain regulations in countries where they only give prophylaxis to up to a certain age. There could be the availability of products or many other reasons. But we can see here, even in developed countries, that the amount of prophylaxis decreases when those patients get to the age of 18 or older. And I think this is something to really think about. So the question comes, is there really a difference between hemophilia A and hemophilia B? And, I went to search on the literature, and I saw even starting in the 1950s, where the investigators, the treaters were talking about that there might be a difference, especially clinically, between the two diseases. There are some literature, talking about these differences, and many comes from retrospective studies. So let me just go and talk about a few of them because of time. I cannot go into a lot of detail, right? Here I have a table explaining the differences between hemophilia and hemophilia B. Again, both are located in the chromosome X, and we can see there is a big difference in the size of the molecules, right? Factor 8 has 26 exons compared to hemophilia B with only 8. Now, in terms of symptoms, they seem to be quite similar in terms of how these patients present clinically, right? Hemarthrosis, hematomas. The bleeding frequency, even in the studies, is quite similar. Now, at age of when they have their first joint bleed, it seems like maybe hemophilia B might be a little bit later, but not a huge differences. Now, the difference is really coming when we start looking at the genetic defects, as I already mentioned. Most common for hemophilia A, severe, is going to be the intron 22 inversion. But in the hemophilia B, we have the missense mutations. Now, in vivo recovery is also different. Remember, factor 9 has more extravascular distribution, so we're going to see a different in that. The half-life is also different, 18 to 24 hours in hemophilia B compared to only about 8 to 12 hours in hemophilia A. Now, there's also a big difference when it comes to inhibitors. We see that we have much more inhibitors in severe hemophilia A compared to B, only less than 5% of those patients. And then there are other unique characteristics of the inhibitor patients. For example, anaphylaxis is seen mostly uniquely only in patients with hemophilia B, and usually is in those patients when they develop the inhibitor. Some of them can develop reactions to the factor 9. It's really not seen in hemophilia A. Now, in terms of success of the ITI, we see that is more common in patients with hemophilia A. Hemophilia B patients don't respond that well to immune tolerance. And also, the nephrotic syndrome is a complication of patients with hemophilia B that undergo immune tolerance. It's really not described at all in patients with hemophilia A. So we see there are some differences despite, both having hemophilia. So do we think that patients with hemophilia B might have a milder clinical manifestation than hemophilia A? What are the possible explanations for this, if there are any? Well, I already talked about the underlying gene defects. That certainly is a big difference. And it's possible that those nonsense mutations might be partially rescuing, those severe hemophilia B patients, maybe. Is there a bias in terms of the limits of measuring and reliability of the clotting assays for specifically for factor IX. That is, again, difficult to say. Now, when it comes to maybe the limits in detection of the residual factor IX that is maybe distributed extravascularly, what is that pharmacodynamics of that extravascular distribution? I think we know little about it, and what is that role of that extravascular factor IX really plays here. That, again, I think there's not a lot of information, at least that I could find. So what is that evidence? Well, there are really no prospective studies that compare, one or from the other. Again, the literature is somewhat contradictory. But we've seen from the studies that there are available that there are less prophylaxis given to patients with hemophilia B. It seems like they maybe bleed less. Again, a lot of this data is retrospective studies. They seem to have lower maybe HSS scores, less arthropathy, maybe less surgery in patients with hemophilia B as well. So I'm just going to talk about a few of the studies. Again, I don't have time to go into a lot of details. This was some data that came from Scotland from the 1980s, looking at demographic characteristics, hospital admissions, and cause of death. It was a small study, 282 patients, where they had 76 with hemophilia B and 206 with hemophilia A. And what they saw was that there were less hospitalizations in patients with hemophilia B, only 11% when they compared to 77% of the hemophilia A's. When they looked at the total deaths, only hemophilia A patients died here, but there are multiple causes of death, right? And if we look at only bleeding, we saw that 12 of them had hemophilia A. And again, none of the hemophilia B patients died in this study. Again, it's a very small study and it's a retrospective study. Now, this is actually a more interesting study that came from Italy. They looked at they looked at instrumental, serological, and histological findings in patients with hemophilia A and B. And what they found here is that in patients that have less than 10 hemarthrosis, it was more significant in the hemophilia B group. When they looked at patients that have between 10 and 50 or more than 50 hemarthrosis, it was higher in the population of hemophilia A patients. When they looked at the scores, the Wolf-Rayet hemophilia score, the ultrasound score, they saw it was worse in the patients with hemophilia A when compared to hemophilia B. Now, when they looked at the ultrasound findings, they saw that patients with hemophilia A had larger effusions, and those individuals also had more cartilage modifications when compared to the hemophilia B. They also saw that the patients with hemophilia A had more bone remodeling and more osteophytes when compared to the hemophilia B patients. So again, there seem to be some differences among the two different diseases. This was a study that was done in the US, looking at prophylaxis among patients specifically with hemophilia B. It's a registry that came from the CDC and the UDC, which encompass most of the hemophilia centers in the country. And we see that there's a large number of patients, over 2,400 males that had moderate to severe hemophilia B of all ages, from 2 to 79 years old. What they found was that the prevalence of prophylaxis in this group of individuals was only 45%, actually quite low when you compare to severe hemophilia A. And they saw the prevalence of prophylaxis in moderate hemophilia B was about 25%, which I think is what is expected, or we see in the literature as well. Now, when they looked more in detail, which were the patients that had more prophylaxis, they found that was the younger age group between 6 and 11 years old, and it was more prevalent in the Hispanic population in this specific study. Now, this is another study was done in the US, and they looked at the frequency of joint hemorrhages and procedures in non-severe hemophilia A and B. It was data collected over 12 years, and again came from the same registries. Over 4,700 patients, of which about 1,450 patients had hemophilia B, again, ages between 2 and 91 years old. And the factor levels range between 1 and 49. What they found was that joint hemorrhages and orthopedic procedures were more frequent in patients with hemophilia A. And, looking at prediction model, they saw that levels probably of 20% or higher were required, again, to prevent joint hemorrhages. Now, one of the interesting things here that they found is that age was the most important predictor of bleeding rate. And it seems like patients between the ages of 25 to 44 years old was the group that had the more bleeding rates in this specific group. And as we can see here, there was a difference between the A's and the B's. It's predicted that, an individual that has, let's say, a factor 9 activity of about, 20% or so with hemophilia B, this patient is predicted to have maybe 1 joint bleed every 2 years. And if you compare it to somebody with hemophilia A, the prediction is that this individual will have 1 bleed per year. So certainly double the amount when you compare to hemophilia B. So again, because of time, this is all the information that I can present, but I hope that I was able to give you at least some information for you to start thinking about, really, is there a difference between hemophilia or hemophilia B? And I'm going to finish with this slide, just bringing up some challenges. We know that the prophylaxis is probably underprescribed in a group of hemophilia B patients. It seems like there are much less moderate patients that are not receiving prophylaxis. And again, this is based on some of the data that is available. I bring up an important point here, and is it possible maybe that if we start using some of the long-acting factor 9s, could this maybe be able to provide more prophylaxis to our patients? Is it more cost-effective? I think this is a question that it will be important to have some data. Are we doing less surgeries in patients with hemophilia B when we compare them to hemophilia A? That is what the literature so far is showing. Certainly, there are some issues with the assays, and I think Suresh is going to talk about this, especially some specific extended half-life factor 9s. This could maybe be an issue in certain centers or in certain countries. And the last question is, can the new molecules, even including gene therapy, is it going to maybe change the way we manage our hemophilia B patients? So I'll stop here, and we'll introduce then Suresh, if he can go ahead and start his presentation. Thank you.
Thank you, Miguel, and thank you, Glenn, for the introduction. So my job is talking about assays and reagents for diagnosis and treatment efficacy in bleeding disorders, not only hemophilia, especially in the special context of low resource setting. So when we talk about factor assays, factor VIII assay, you have the one-stage APTD-based factor assay and the chromogenic factor assay. The reagents that are required for the one-stage, it's an APTD-based assay. Primary important reagent is the factor-deficient plasma. You can obtain it commercially, or you can make it in-house. I'll tell you how to make good quality in-house factor-deficient plasma. Then, of course, you have the normal reference plasma, which is again available commercially, or you can make your own in-house pool normal plasma, which can be assigned a value so that it becomes a reference plasma. Then, of course, you have the buffers, the APTD reagent, and that takes you to the one-stage APTD-based assay. There are limitations that have been identified in the one-stage APTD-based assay, especially because of its susceptibility to interferences, especially from patients who may have lupus inhibitors or poorly collected samples which get activated, sometimes over-exaggerating factor levels in patients with hemophilia. Some of the mild, moderate hemophilia A can only be identified by a chromogenic assay and not by the one-stage assay. It needs a two-stage assay. Chromogenic is being one of them. Then the most important thing is misleading results when assaying recombinant factor VIII infused into a patient, which is the factor VIII recovery assay. So the data has very clearly shown that the one-stage assay underestimates the factor VIII levels by 20 to 30% when compared to a two-stage assay or a chromogenic assay. So that by leading to underdosing or suspected underdosing of patients, whereby they get unnecessarily extra factor VIII because they can only be assayed by the one-stage factor VIII assay. So the chromogenic assay is also a two-stage assay because it looks at two steps, and one primarily depends on generation of factor Xa, which of course with the help of factor VIII that is in the system, either the patients or the infused factor VIII. And once the factor Xa is produced, it will be subjected to a color changing peptide, whereby it can indirectly tell you how much factor VIII is in the patient. Now that is as far as chromogenic and factor recovery assays are concerned, but what does extra information EHL brings into factor assays, especially the APTT based factor assay, which is very commonly available in most of the hemophilia treatment centers. We all know that APTT reagents vary with the activator or the contact activators that is there in the system, like it can be ellagic acid, silica, or kaolin. And the other variable is the combination of the phospholipid, which is the partial thromboplastin. That's why it's activated partial thromboplastin time, which is predominantly phosphatidylserine, phosphatidylиnositol, and phosphatidylethanolamine. We know that APTT reagents vary with sensitivity to factor deficiency. You know, it will be probably responsive when the factor levels are around 25%. You'll be lucky if it's 35%. It's able to respond when it's 35%. Sensitivity to heparin, because it's used to monitor heparin. And of course, diagnosis of lupus anticoagulant is also depending on APTT reagent. And they generally will be classified as factor sensitive, heparin sensitive, and lupus sensitive. We try to use a lupus insensitive reagent for screening in the lab, because it should be only sensitive to factor deficiency and respond to heparin, but should not be sensitive to lupus. And usually people suspect that the insensitivity to lupus is brought about by increasing the phospholipid content. Not necessary, it may be there, but changing the phosphatidylserine in the composition can also make it lupus insensitive. But you must realize that the phospholipids are important because it allows the formation of the two enzyme complexes, the tenase complex and the prothrombinase complex, which creates thrombin to produce the fibrin clot, which is the endpoint for APTT. Now, obviously, we realized that we were only obsessed about the phospholipid content, but looks like activators are also involved in the variability. So one thing that people have realized, that enzyme complexes which were forming on the phospholipid surfaces, the anionic phospholipid surface, can also form on particulate activators like silica and kaolin, whether they are the colloidal form or particulate form. And in this process, they either get consumed, therefore they are prevented from participating, leading to underestimation of the levels of factor, or they may get activated and leading to overestimation of the levels of factor. So data have shown that pegylation is one particular way. This is an example of NHGP. The one-stage clotting assay, the majority of the APTT reagent shows acceptable NHGP recovery. However, the 3 silica-based APTT reagent, which is APTT-SP, Triniclot, and STA PTT Automate, underestimate the NHGP activity. Chromogenic assays, fortunately, are not that bad, but they might slightly overestimate the NHGP recovery. Now, coming to the BAY 9027 reagents, the silica-based reagents like APTT-SP and STA Automate can underestimate. Again, say they are silica-based activators. However, the kaolin-based activators like Actin-FS and CK-Prest can overestimate the levels of the extended half-life factor. Now, coming to the possible explanation for overestimation, may be due to premature activation, which can be triggered by the PEG-mediated co-localization of the N8-GP with factor 9A and the plasma kallikrein on silica particles. However, chromogenic assays are not effective. The functional interaction with PEG, chromogenic assays are likely to be insensitive to pegylation due to more stringent activation conditions. So therefore, chromogenic assays are reliable in analyzing some of these extended half-life factors. So this is the data that shows the variability in the various APTT reagent. Almost every APTT reagent that is used in the hemostasis lab is there here. And when you look at the variability and compare it with the various chromogenic assays available, you can see that there is good agreement between the chromogenic assays compared to the one-stage APTT-based assays. So one-stage APTT-based assays is a matter of concern, but it is not completely to be avoided, because certain of them, certain APTT reagents do very well with certain products. Now, coming to the factor 9, as Miguel mentioned, that the extended half-life product also has similar issues. There again, the APTT-based reagents, silica-based reagents, actually can actually overestimates the factor 9 activity. However, the chromogenic assays are quite reliable in extended half-life factor 9 products. So with the resource limited settings vis-a-vis factor 8 recovery assay, there are challenges and uniqueness with different EHL factors. one needs to be mindful of the appropriate reagent in case monitoring is done to avoid under or overdosing. Most importantly, the unique reagents that are applicable for EHL factors, are they available in resource limited settings? So I'll show you some data that is from the WFH IQOS, which has about 94 hemophilia treatment centers, which are sponsored by WFH. Of course, there are other labs which pay on their own, but these are hemophilia treatment centers identified by regional managers to participate in this program. So they get an opportunity to compare themselves with other peer hemophilia treatment centers. So you can see that in the APTT test, 22 of them do not return the results because there are no reagents available. So you can see that APTT reagent availability is a big question. So looking for the particular type of silica-based or kaolin-based APTT reagent may be a bigger limitation. And then you have only 56.4% of the laboratories which are returning the factor VIII results, but none of them do chromogenic assay. All of them do APTT-based assay. So there is an issue with factor VIII assays also. Now coming to von Willebrand's disease diagnosis, other than APTT and factor VIII assay, of course, there are other specific assays like antigen, von Willebrand's antigen, RECOF, and collagen binding assay, which are activity-based assays. Now, there are 86 laboratories which volunteered to participate in the von Willebrand's testing of the IQOS, of which 86 of them, all of them do factor VIII assay. But those who do combinations, and especially the combination which covers the entire diagnosis and sub-classification of von Willebrand disease, there are only 36 laboratories which are doing factor VIII and antigen as well as RECOF. And among these 36, 18 of them are persistent outliers. So diagnosis of von Willebrand's disease is also a matter of concern, especially even if they have a APTT-based assay, none of them have chromogenic assay. So now this is a data that has, this is a combination of data which I got from the WFH global survey, which is on the left-hand side. And on the right-hand side are the various diagnostic test kits that are manufactured by manufacturers and supplied into this region. You can see that countries like Philippines, Cambodia, Nepal, Indonesia, and Myanmar are not getting any of these kits. So obviously, if without these kits, they cannot make a diagnosis of von Willebrand's disease. But if you look at the global survey, many of these countries do report patients who have got von Willebrand's disease, maybe because they are doing APTT and a factor VIII assay. But in addition to that, they may be doing a skin bleeding time. Though it's a most difficult test, needs a good understanding of its performance characteristic. It is the only way, if you don't have any specific von Willebrand's assay, to make a diagnosis of von Willebrand's if you have a factor VIII assay or an APTT going in your lab. Of course, an operator who does bleeding time can also get to realize by looking at the wound, the way the wound is welling up. In 30 seconds, if the wound is not welling up this much, that means the standard skin wound was not made properly. So the operator can be trained to evaluate whether the bleeding time he's doing on a particular patient is going on well, and they can also document it by blotting it. The size of the blot will tell you whether the wound was created well. This can also be kept archived and kept in the patient's file in a Ziploc paper, bag. So this becomes a permanent record for the patient. So yes, people have criticized skin bleeding time, but some of the countries do depend on skin bleeding time for a diagnosis of severe von Willebrand's disease. So this is the data that is from 445 patients that was diagnosed with von Willebrand's disease in our lab. And you can see that majority of our patients are type 3 because we see a lot of consanguinity in our region. And if you look at the help of bleeding time in making a diagnosis of patients with severe type of von Willebrand's disease, especially the type 3 and the type 2, you can see how much bleeding time has contributed to the diagnosis of von Willebrand's disease. Of course, we do a lot of specific tests, but skin bleeding time should not be ignored, especially if you don't have any other access. And for example, this is a data that has been published earlier. You can see that majority of the patients with von Willebrand's disease belong to the type 3. So more severe form. So they are not difficult to identify by skin bleeding time. Now coming to my last slide, which is not last set of slides, which is basically how do you make some in-house modification to the factor VIII recovery assay? And can you overcome the lack of availability of chromogenic assay? of course, it starts with obtaining a good factor deficient plasma. So in the next slide, which is quite a busy slide, there's a combination of 16 patients with severe hemophilia A. And on the column, you can see various types of pool normal plasma or reference plasmas. And you can see that the first dilution, the timing is usually between 48 to 55 seconds. And the difference between each dilution is not more than 5 to 8 seconds. So if you can fulfill that criteria itself, you can easily make out the diagnosis. And of course, if you want to store it, you can see that you sorry. I think I unmuted myself. Okay, the last slide is how there was at one time an article published by Trevor Barrowcliff from NIBSC when the issue of one-stage assay underestimating the factor rate recovery compared to chromogenic assay or a two-stage assay. He came out with a like versus like principle, which was a good solution. That is, he said that all the factor rate concentrates are assigned potency with using a two-stage assay or a chromogenic assay in those days. So why can't we spike a factor rate deficient plasma obtained from a patient or from commercially with the same factor concentrate, which is being infused into the patient to achieve a 100% level of factor rate, 1 international unit per ml, and use that plasma to make the standard graphs. And that actually help overcome the difference between the one-stage assay and the chromogenic assay. And from then, so the interesting thing was that we saw that article and we have been using that in Vellore till we got chromogenic assays many years later. And it worked very well. Unfortunately, I don't know, I did not preserve that data because I realized that the rest of the world, which may have had an access to this article, continued doing chromogenic assay. So, you know, the comparison between the factor rate concentrate recovery assay on a like versus like principle, I think the data is lost. So, but it still works very well for us when we run out of chromogenic assays. So that's all I have to say. Thank you very much. And now I'll request Dr. Annette to take on the session.
Good morning. My name is Annette von Dregalski. I'm a professor of clinical medicine and the director of the Hemophilia and Thrombosis Treatment Center at the University of California, San Diego. And it is my pleasure to talk to you today about the topic, is it a bleed or not? Something that truly influences our management and we need to know. So let us get started with a pictorial schematic of hemophilic joint damage as it relates to hemathrombosis. Once blood enters the joint space here, iron is released from red cells or from macrophages digesting red cells, and that iron seems to be the culprit for down the line or downstream cartilage damage, synovial hypertrophy with neoangiogenesis. Just keep that part of neoangiogenesis and perhaps vascular remodeling on your mind. So what could be potential bleed sites? I think we all can agree that first bleeds that might then lead to target joints are intracavitary, so into the joint space. That is sort of the traditional classic way regarding looking at joint bleeds. However, once the arthropathy progresses, there might be additional potential bleed sites that are less well understood. For instance, with synovial hypertrophy and more vascular remodeling and neoangiogenesis, there is soft tissue bleeding. And furthermore, with cartilage destruction and subchondral cyst formation, there can be bone bleeding. So what is the evidence for these different bleeds or bleed sites? Soft tissue, i.e. mostly synovium, bone, or intracavitary. Let's review. Synovial bleeding. There are very suggestive findings in terms of hemosiderin deposits in synovium. This is a very old image from a surgery performed in 1977, but you can see the massive hemosiderin and blood enrichment in the synovium upon surgery. And this here is the depiction of synovium, hemosiderin in the synovium on a conventional MRI. So you see here the yellow arrows point towards hemosiderin artifacts concealing actually the synovium, and the radiologists call that zero signal and blackout. So clearly there is bleeding in the synovium. And this leads us to the concept of vascular remodeling, something I like personally to call quote unquote vascular bleeding. So as we all know, joint bleeding is associated with reactive synovial hypertrophy and vascular remodeling. That vascular remodeling, and I show you some images just below and will explain that to you, is associated with vessel fragility and more bleeding. And then more bleeding, of course, fuels more vascular changes with even more bleeding. So we get into this vicious cycle of vascular bleeding. And that's somewhat independent of coagulation, or let's say hypocoagulability or factor deficiency. Now, what is the evidence for that? You see here in explants of human and synovium and mouse synovium in factor VIII deficiency, so in hemophilia A, in osteoarthritis or in rheumatoid arthritis, pronounced expression of alpha SMA, that is a mesenchymal marker of vascular remodeling. And these are the structures here. You see these huge vessels, and they are very expressive in terms of this alpha SMA, i.e. remodeling unstable. And that is true for the factor VIII deficient patient and for the mouse model. You see much less of that in models of osteoarthritis or in rheumatoid arthritis. So this is really unique to hemophilic joints. And this here is the depiction of a patient of mine who suffered 8 years after liver transplantation from a really, and therefore normal factor VIII levels, from a really significant bleed into the elbow. And you can see here on the angiogram, the vascular aberrancy. There's also contrast extravasation at the time. And this would be a power Doppler image, an ultrasound image with power Doppler showing these large remodeling and leaky vessels. So the same principle applies to subchondral cysts and something I like to call now bone bleeding. The suggestive finding here is the finding of hemosiderin deposits and that vascular remodeling in subchondral cysts. So you see here by explants by histology, and you see the cystic content. It's very cellular. And here again, just as before, these large remodeling vessels, very positive for alpha SMA, and also in blue here, lots of hemosiderin deposits by Pearl's blue stain. And then here on the MRI, again depicted by yellow arrows here in black and dark, pronounced hypointense lining at the subchondral medial femoral condyle. So this is the area of cysts, and this is hemosiderin deposits. Hemosiderin deposits are also present in cartilage. Now, cartilage is avascular, so not quite clear how the hemosiderin gets there, perhaps by transport by reticuloendothelial cells such as macrophages, not sure, but you can see here in the explant hemosiderin deposits by Pearl's blue stain in association with chondrons. And that is also depicted here on an MRI by T2 star iron quantification with iron accumulation in the patella cartilage in a patient with severe hemophilia A. So altogether, this leads to a bit of a proposed bleed evolution over time once we come to bleed sites. Perhaps in infancy, this is truly all intracavitary. This is how it starts out. And it continues to be intracavitary, but we add additional bleed sites as we age. So this is synovium, and then finally subchondral cysts / bone. So I call this phenotypic bleeding add-ons over a lifetime. Now, the extent of hemosiderin accumulation in cartilage and subchondral cysts really matters because iron is a toxic payload. And that's shown here to the left in terms of quantification of hemophilia joint health scores on the y-axis and MRI scores here also on the y-axis, and iron accumulation measured by T2 star in cartilage. And so the shorter the T2 star, the more iron and the worse hemophilia joint health score or MRI score. So the iron accumulation in cartilage correlates well with worsening joint health. And moreover, the hemophilia joint health score is worse in joints with a high cystic iron content in hemophilic patients. So all of this is good, but how to know when joint pain is related to bleeding? Because bleeding matters and we have to diagnose it because of all the sequelae I just showed you. The problem is that joint pain symptoms and findings, all that patient experience and that we look at or we palpate are non-specific, such as swelling, redness, loss of range of motion, pain, warmth. There is really no easy discrimination between underlying etiologies. And I just took a couple of pictures here from the internet relating to hemophilic arthropathy, gouty arthritis, rheumatoid arthritis, reactive arthritis, Charcot arthropathy, and osteoarthritis. It all looks and presents rather similar. So this has spurred an increasing demand for point of care here, short POC, musculoskeletal ultrasound MUSCAS, mainly to detect joint bleeds. Because the clinical exam and patient perception has shown to be unreliable and non-specific. And now I want to add here for intracavitary bleeds, because this is what ultrasound can pick up. So bloody effusions are easily detected with MUSCAS. They are compressible spaces with sonopalpation, and bloody means mixed echoes with displaceable speckles or material, and ultrasound can really detect very small volumes of blood, 3 to 5 milliliters, with much higher specificity than MRI. So how does ultrasound generate images? Well, these are echoes reflected by tissue structures, and they create an image. So here you can see the pictorial, the anatomic pictorial to the right, and an ultrasound image to the left. And it's personally, I find it's quite amazing how the details are depicted. So this would be the bony lining of the femoral condyle. The black structure is cartilage overlying, and then a little bit of fluid here in the suprapatellar bursa. By the way, that is my knee, so it's just a tiny amount of physiological joint fluid is well separated from cartilage by this so-called interface sign. And on top here, we have the patellar tendon going into the patella. So a quite anatomical picture with ultrasound technology. Now, how do we distinguish bloody from serous effusions? So we hold our ultrasound probe to the lateral recess, and we see here 2 effusions. One is a simple effusion, an anechoic, and the other one is an effusion here, hypoechoic with speckles. These are bloody components, and here you can see the aspiration result in the syringes. How do we distinguish fluid from synovium by sonopalpation, since the gray or black shades of synovium can be very similar to fluid? Well, fluid is compressible and synovium is not. We are again in the same area in one of the recesses, and you can see here swinging in and out of plane, some tissue components, but this is an effusion here, it's compressible. Compared to here, this would be synovium, this black area, but it's not compressible. And by the way, this synovial expansion here is 7 millimeters. Normal would be less than 2. That can be precisely measured by the so-called Shade protocol. And just as an aside, so synovial thickness, cartilage thickness, and length of osteochondral alterations all correlate rather well with hemophilia joint health score. Another feature of ultrasound or MUSCAS is power Doppler. It really can show you the extent of this abnormal intra-articular vascularity or vascular remodeling, indicating inflammation. So for instance, here we are at the subtalar joint of one of my patients with severe hemophilia A, 53 years old, and he is 2 weeks post ankle bleed. And this is his baseline, and it's called the sustentaculum here. Again, we are in the subtalar joint space, and this is what he experiences 2 weeks post-bleed. The bleed has resolved, but there is just this increased vascularity and power Doppler signal And so the question is such a patient at increased risk for rebleeding given that vascular signal? And does that matter in terms of our rehabilitation program for that ankle? If in doubt, if you have the ultrasound available to you and you apply it to detect bleeds and effusions, sometimes it's not quite black and white. For instance, in this patient here with severe hemophilia B, with severe arthropathy, he has a replaced knee and he comes to clinic with acute pain and swelling. So here in the suprapatellar bursa, I can see some fluid and perhaps some soft tissue or blood clot upon compression, but the compression is not complete. And the same here in one of the recesses. And again, you see this fast power Doppler signal indicating that perhaps vascular remodeling and vascularity is contributing to the bleeding. So if not quite sure, and also you feel that therapeutically it could be beneficial to get the blood out, maybe aspirate. And we do this here ultrasound guided. And then, of course, this patient got factor IX replacement, a dose prior to aspiration. But here you can see the proof is in the pudding. We withdrew about 10 milliliters or so frank blood. And this is the post immediate after ultrasound posterior shadowing here from the prosthesis. But now all these spaces are cleared, and that clearly contributes to overall patient well-being at this point and less iron accumulation in the joint. So what about ultrasound equipment? I understand it is expensive and not everyone can have that in clinic, but this is where these new handheld devices come to the fore, and they open absolutely a new era for MUSCAS and rapid bleed detection, and that might really benefit patients. So in a global survey that was recently performed by the IPS study group, it turns out that MUSCAS has been found most useful to confirm or rule out acute joint bleeding among all the other applications like long-term follow-up, etc. So the acute, immediate point of care, put the probe on the patient and see if there's bleeding and not, has been found most valuable by in an international study with over 100 centers, I think, questioned. So here you see an image with a really high-end stationary ultrasound machine in terms of bleed detection. So this would be the patient at baseline and longitudinal and sagittal axis done with ultrasound. And this is upon the time when the patient came in acutely to clinic for a joint bleed. So clearly you can see here the fluid accumulating in the joint space. It's always good to have a baseline image of the patient to see what's happening acutely. But now we hold a handheld probe to the joint, and this is the result. So it's clear that effusion detection is feasible with handheld devices. The image with such a machine or such a, let's say, handheld device that plugs into your iPhone or into your Android might not be quite as crisp, but for the decision, bleed, yes or no, it's absolutely sufficient. And we and others have shown that non-radiologists, meaning hematologists like myself, physical therapists, nurses, can easily recognize landmarks and effusions in hemophilic joints after basic training. So these devices really open up a new world, I think, and they are relatively cheap compared to the large stationary or even laptop machines. And to take this one step further, there is now, if someone feels they don't have enough training, or even if patients feel they could have small handheld devices at home and image, it can be done. And this is because most of these new devices have teleguidance options, as you can see here to the left in this photograph. So that teleguided self-imaging of hemophilic joints is feasible, or let's say teleguided imaging of healthcare providers who don't feel quite as trained with someone more trained or more expert like remote. And so here, this is a pilot study. It was just published with 10 patients where we applied teleguidance using the JADE protocol. So patients acquired images accurately with near perfect image quality Image acquisition was fast, ± minute per view, and patients rated that it was easy to navigate this mobile technology and acquire images with teleguidance. So this is Peter, our physical therapist, and that would be myself, guiding patients. We can see them on the monitor. They can see us. We can see their joints, the positioning of the probe, and the image they produce. So it's really efficient and fast. However, when MASCAS is not available, well, there have been several symptom-based algorithms developed in the past several years with self-diagnosis for hemarthrosis and to help distinguish arthropathic pains from painful hemarthrosis. However, none of these algorithms is validated objectively by imaging studies. So we have moved forward and have created a MASCAS validated symptom algorithm. It's now available. And this is a patient-derived assessment tool using musculoskeletal ultrasound for validation of hemarthrosis. So the study design here included 79 painful episodes that were evaluated with MASCAS to determine hemarthrosis. And then prior to MASCAS, a questionnaire was administered to the patient who had the painful episode with 20 questions. 10 were associated with hemarthrosis and 10 with arthritic pain, and the questions were scrambled. And that questionnaire had been developed by the Canadian Hemophilia Society with experienced international hemophilia patients. And these were the results. In essence, we could tabulate the 20 symptoms by increasing odds for hemarthrosis. So going down this line here, the odds of hemarthrosis or experiencing hemarthrosis increased quite significantly. And then the same, of course, in the other direction, an increase in likelihood of arthritic pain compared to hemarthrosis pain. And that led to the development of a predictor tool. Now, this is all preliminary, but it is kind of desirable that patients or even physicians could go about a yes/no for experiencing a particular symptom and then come up with a score and a likelihood of bleeding versus not. Now, this tool obviously requires broader validation, but it is another way to support ultrasound. So to summarize, the determination of joint bleed yes/no is definitely important for management. It is increasingly critical in the era of non-factor or gene therapies to determine is or is there not a bleed, because it matters for treatment. MASCAS is valuable for point-of-care management for bleeding and associated musculoskeletal abnormalities in hemophilic joints. Handheld technology is revolutionizing the field, and really democratizing ultrasound is important to advance our understanding of hemophilic arthropathy and of bleeding and of bleed complication and diagnosis. Patient questionnaires may be useful too, but they do need imaging associated cultural and language specific validation in a broad sense. And then pain contributions by soft tissue and bone bleeds and their best management are really unknown, and this is just coming to the fore more recently. More clotting factor may not always be the answer, and very good would it be to have a measurement of hemosiderin accumulation in joint tissues as a tool to assess asymptomatic silent bleeding and soft tissue bone bleeding. So that would be the answer, but that is under investigation. And this will require the development of quantitative MRI sequences, something for the future. And with that, I thank you for your attention, and I'm looking forward to the question and answer session. Thank you again.
Thank you very much. Oh, go on, Marlene.
Oh, you're there.
I am, but go on.
I thought you already left, Glenn, so that's why I thought I had to take over. But since you're still there, please go on.
All right, well, thank you, Annetta. And I really want to thank all 6 of our speakers who have done an outstanding job of giving us a good perspective on comprehensive care for bleeding disorders, in this case focusing on not only teenagers, but on some of the morbidities that are associated with hemophilia. We may have time for 1 or 2 questions. We've answered a lot of questions in the question and answer area. association, is there an association between blood type and mutations of hemophilia? Miguel, do you want to take that?
Again, association between blood type and mutations, I do not know of any association between the two. I think they're completely, separate things, so I don't think so.
Yeah, I would agree with that. There have been some questions on sports that I think Cesar has answered more completely. Are there any additional questions, Marlene or Julia, that you can see that I can't see?
Glenn, I think there's one question here. They're asking about the statistics for females in terms of hemophilia symptomatic carriers. I think this is a very important point. And I encourage, everybody to try to include their patients in the different registries so that we can have accurate data, especially in females. There's the World Bleeding Disorders Registry. There's a registry from the ISTH as well. I can tell you that we're collecting data in the US, and so far, up to last year, we had a total of 1,925 females with hemophilia. Those either severe, moderate, or mild. So I think the more we look, the numbers are going to keep increasing. So I really encourage you to go ahead and try to get into these registries, your patients.
And Glenn, the last question in the chat is about in developing countries that still have difficulty in carrying out prophylactic treatment in hemophiliacs, what strategies can be taken to provide understanding to the government to develop policies that support prophylactic treatment in patients living with hemophilia?
Yeah, well, that's not an easy short answer, is it? A lot of it comes down to advocacy by the National Member Organization, advocacy by the hemophilia treatment centers that are within the country. One of the reasons we established the World Bleeding Disorders Registry is so that you can have quantitative data. How are your patients doing? Or how poorly are your patients doing if they don't get access to therapy? What's the rate of joint damage? What is the rate of mortality? And what can be done? Prophylactic therapy, with on-demand therapy, with the availability of clotting factor concentrates. And so all of that has been recorded in the countries that are using the World Bleeding Disorders Registry and can be used as ammunition for the government to show the cost effectiveness of actually treating patients with hemophilia, rather than putting them in a situation where they don't get treatment and become a cost center for the government. So continue to work with the WFH, with the national member organizations, to develop the data that you need in order to advocate for government support of hemophilia treatment centers, as well as purchase of clotting factor concentrates.
And
with that, I think we're going to go on, Sue.
I was just going to add my experience when we twinned in Botswana is that the director of the center, the physician, really established a nice relationship with the Ministry of Health. And we were involved in going several meetings with the Ministry of Health, and he had ongoing meetings, and it really helped to increase their understanding and their receptivity to funding factor. So just that opening up that communication and collaboration.
Yes, making them part of the solution, not part of the problem.
Yes.
All right, with that, I really want to thank our speakers again. We had a great session, and as I mentioned earlier, this will be online in 1 to 2 weeks, so you can review it. If you haven't heard all the talks, please do join us online. Thanks again, and have a good day, everyone, or good evening or good night.